واشكر طبعا استاذي دكتور يوسف صالح، وبشكر دكتور مدحت العربي ودكتور أسامة العشيري على الدعوة الجميلة دي. So proud to be here in Asyut University, my university, and on behalf of my Prof Osama Taha and my group, Osama Taha group, I would like to talk with you about today the recent advancements in bariatric surgery. And actually, I would like to talk about the recent advancement in everything, in definition of obesity, in how to diagnose your patients, and finally, we'll give a light and highlight about the advancement or recent advancement in bariatric surgery. I would like to begin with the definition of obesity that we believe is the old definition. It's a systemic disease that show excessive and abnormal accumulation of fat with its drawbacks on general health. But actually, we know the comorbidities of obesity. Nowadays, you have about 50% of patients diagnosed with diabetes are obese. And at the same time, the risk of type 2 diabetes actually increase up to 20% for every 1 kilogram per meter square rise. So, from here I want to thank Dr. Medhat Al-Arabi and Dr. Osama Al-Ushiri to trying to reaching their message that to fight obesity, you need a multi-speciality, not only one specialty. All specialties should be working together to fighting the obesity and its comorbidities. So, we think the ideal definition that the obesity is a systemic syndrome, not a disease. And for this reason, the WHO and our International Federation of Surgery of Obesity shifting the name of bariatric surgery to be a metabolic surgery, not a bariatric surgery. And for sure, here is our numbers of obese and overweight. And for sure, the highest BMI here that we find in Middle East and North America. So, for sure, when you're categorizing body weight, you are thinking about BMI, waist circumference, and waist to hip circumference ratio. BMI is more familiar to all of us and familiar to a patient as well. So, most of us facing the same problem. When the patient just texting you, calling you, or sending you like a message on social media, and told you, doctor, here's my height, and here is my weight. Please find me the best solution, or please use for me the best diet plan. But actually, the BMI is not the only method that helping you. When you have a look to these two guys, both of them has a BMI 35 kilogram per meter square. I don't think that anyone can tell me that the guy on the left side is obese, is healthy. And here is our limitations for BMI. First of all, it doesn't provide any information about fat distribution of the body. And at the same time, it not give us any idea about the proportions between adipose tissue, muscle, and bone. So, the WHO and EFSO as well as working hard and trying to shifting to using the BMI to the waist circumference or waist circumference to hip ratio. And here is the cutoff of waist circumference, which helping in diagnosis of obesity and diagnosis of comorbidities as well. So here is a small history about the bariatric surgery. Actual bariatric surgery is began at 50s by the open gastric bypass, and at the 80s began to using the vertical band gastroplasty, and at 90s when appearing the laparoscopic solutions, it's shifting and tenfold growth worldwide in the past 2 years for bariatric surgery. And what we have here is rapid increasing in number of performed bariatric surgeries over years. And when we have a look about the types of bariatric surgery, we found that the laparoscopic gastric sleeve is rising so fast, and at the same time we have a little bit downgrading for the gastric bypass, and the gastric band is going down up to 0, and I think within few months the laparoscopic gastric band will be aborted and illegal. So I will begin to discuss with you some recent techniques of bariatric surgery and discuss with you about its advantages and disadvantages. We have here, like, all of us knowing the gastric sleeve. So some schools just talking about using a elastic band around the gastric sleeve, trying to delay emptying and at the same time make the patients feeling more fullness. But actually, when you have a look to this study, the banded sleeve showed a little bit improvement in weight loss and maintenance in the red row, and at the same time, when you have a look to the other study, you found that 40% of patients underwent a banded sleeve suffering from vomiting and bad quality of life. So you should balance between weight loss and the quality of life. Then I jumping to the laparoscopic gastric plication. Here you just plicate the greater curvature of the stomach. You're not using foreign material, you're not cutting a part of the stomach, you just plicate the greater curvature. And here is our data from our group, which published about 3 or 4 years ago. To be honest, I'm so sorry that we are not satisfied of its weight loss, because we have just 35% weight loss, 23% of these patients stopping weight loss after 6 months, and 11% of these patients begin to weight regain after 9 months. And here's one of the most recent novel techniques, that endoscopic sleeve gastrectomy. You're going by upper endoscopy and begin to suturing the inner layers of the stomach. Here you are away from the fear of gastric leak or gastric bleeding, with a little risk and high safety. And most of published data here show acceptable weight loss results. For sure, the weight loss for the endoscopic gastric sleeve not so high like a laparoscopic gastric sleeve, which appear here markedly significant difference in weight loss for the laparoscopic gastric sleeve. It's not only the only problem, but actually with time, these stitches begin to open gradually. When you have a look to the picture number A, it's immediately after doing the procedure. Picture number B, it's about 3 months after the procedure. Photo number C is about 6 to 7 months, and what appear it's partially open, and the last one is completely open. And when you have to have a look at these studies that published in 2019, that a high instance of opening of all these stitches. Up to some surgeons include this type of procedure as a transient option. One of the new techniques is using the endobarrier, which is like a barrier introduced by the upper endoscopy from the duodenum, covering the inner layer of the first part of the duodenum and first part of jejunum, and it's a malabsorptive procedure which affecting the absorption. And when you have a look here for the Nietzsche et al. Study 2019, we found an acceptable weight loss, but after its removal, after 1 year, the weight began to regain. So it's still in the area of the transient options. And in plastic surgery, sure, we're using like a Botox for wrinkles and the facial aging. The Botox is just going to like a muscle, a little bit transient muscle paralysis, and here using the Botox injection for the stomach by the upper endoscopy. Up till now it's not approved by FDA, to be honest. The aim here is a transient delay of gastric emptying and reduction of the maximal gastric capacity. And to be honest here, is completely unsatisfied weight loss. It's just 4 kilogram per meter square weight loss and still a transient option. Few years ago, using like a fillers or hyaluronic acid injection, it was used for correction of gastroesophageal reflux. And some ideas appear about injection this filler as a gastroesophageal reflux, trying to control food intake. And here in the left side during injection of the hyaluronic acid, and on the left side, on the right side, you found that it is filled with the hyaluronic acid and trying to decrease the oral intake. The result here for this hyaluronic acid injection is very bad regarding weight loss, and just some schools is thinking by using this hyaluronic acid as a combination with the intragastric balloon. And it's a little bit help that when you found this graph, the group on the first group is just intragastric balloon only, and the other two groups associated with hyaluronic injection. So hyaluronic injection alone is not an option, but we can use it with the intragastric balloon to give more weight loss and at the same time a little bit maintenance of the weight loss. Finally, it is the programmed capsule. It's a new era in bariatric surgery. And we are so proud that we were the introducing of this solution to Egypt in 2019. Actually, it's a capsule connected with a catheter ingested in the out clinic with a little bit of water. And this catheter, you can inject in it just a water, which converting this capsule to a balloon. And this balloon will stay in the stomach for 4 months. Then it's gradually excreted. To explain it more, I will show you a video of insertion of this capsule. As here the patients come to our clinic, just using the capsule and ingesting the capsule with a little bit of water. For sure, it's a little bit large sized capsule. And then doing like plain erect X-ray to make sure that our capsule inside the stomach before begin to inflating this capsule. The patient is awake, the patient is joking with the team. The procedure takes about 7 to 8 minutes in the out clinic. So it gets rid of the idea of upper endoscopy, general anesthesia, during balloon insertion and during balloon extraction. And actually within 4 months, the HCL just opening our valve and getting out through the stool. So your patient is completely away from the anesthesia or the OR for about either during insertion or outsertion. This scale have like a story, yeah? This scale is in-body scale connected with Bluetooth with your phone, and once you using this scale, you have all in-body in your application, and all this body weight is recorded in the platform in Harvard, so they have all the data of weight loss from the capsule worldwide, and at the same time, they know these patients inserted and following the program with which team. And here is comparing the ellipse capsule with other intragastric balloon. It's a little bit showing better weight loss, but we believe that the matter is not like a weight loss, it's a matter of the safety and away from anesthesia. And here is our published data, and we are so proud. It is the first published international paper in the Middle East and Egypt about the ellipse capsule. Here is our data in the first 96 patients, and here is our weight loss. We have about 12 kilogram per kilogram weight loss, I think. And actually we have to look here to our study and other studies, we have a comparable weight loss at about 11.2%. The story here is just not looking to this data, but the protocol that we upgrade in nutrition, which I want to thank my nutrition team, and Dr. Amira is here as well, one of our nutrition team. They're working so hard to upgrading this protocol. And when they're working hard in upgrading this protocol, our data is jumping from 11.2% weight loss to 19.3% weight loss. This data already is recorded by the app that I explained before in the Harvard, and actually it's about 1 week ago we invited by Alorian to achieve the highest weight loss award worldwide, which is an honor for me, for Egypt, and my university as well. And here, thanks God that our team have a 0 placement failure, and for the endoscopic removal for emergency, just 1.6%. And actually, I would thank to all my team, because we achieved actually the highest weight loss worldwide, which recorded there in Harvard by Aloria. So finally, rapidly increasing demand for bariatric and metabolic surgery has been noted nowadays worldwide. Further progress for metabolic surgery will depend on elucidation of the effect of hormones and neuroendocrine mechanisms with individual gene polymorphism. To provide a better metabolic surgery, please train qualified bariatric surgeon, build your system, build your multidisciplinary team. Continue to develop better techniques will be important issue in the surgical treatment of obesity. All my thanks for my prof, my prestigious team,